Good afternoon, everyone. Thanks for being here. It's a pleasure to see you and to welcome you. My name is Mary Haynes. I'm the administrator here, and it's my honor to represent the people who live and work in our two locations here on Newburgh Road and our property in Clifton. We are honored to do the work that we do. We've been around doing it since 1976. Hopefully some of you are not here for the first time, but if you are, that's great. We like to get people in the front door and hope that you get the feeling of our commitment when you come. We're excited to offer this lecture series, this education series this year. We've been doing this since January and we'll continue through until November. On this Wednesday afternoon, the last Wednesday. And what we're talking about are things that people ask us about. As you might expect, we're always in conversation with people in the community, and they want to know how to make decisions when it's time to do this and that. So that's how we've structured this community education. We will be providing you with a survey before you leave here. It's probably in your packet, where we'll ask you about things that you would like to know more about, and we'll build those into our offerings. So again, we're proud of what we do. We always like to say that we're a great place to live, work, and play. We this year have had some nice recognitions. The U.S. News and World Report rates skilled nursing centers across the country. They do that rating by reviewing the Medicare participation results. And this year, for probably about the 7th time, we were rated among the top 10% of the country's skilled nursing centers. So we're proud of that. We like to share that because we hope that we deserve and can maintain the public trust. At the same time, with our workforce, our team members, we entered into 2 local competitions to be top workplaces. One was with the Courier Journal, the other was Business First. And we were named by both of those entities top workplace. Again, we do that because we want everyone to know that we are serious about what we do, we love what we do, and we're committed to it. And we want to be at the top, and we think we are. So thank you for being here this afternoon. It's my pleasure to introduce Dr. D to you, D. Archimedes. Dr. D has been a colleague of mine for a number of years. She's quite known across the Commonwealth and really across the country for her work with medications and their impact on adults. Some people call that polypharmacy. Here at Nazareth Home, we're always working to what we call deprescribing, meaning reducing the number of drugs that people are taking, which I'm sure Dr. D is going to talk about. She's affiliated with the University of Louisville in a Frazier Endowed Chair. She completed her geriatric pharmacy residency in the late 80s out in California, UCLA geriatric site. So she, like some other people here in Louisville, were really on the front end of geriatric medicine. We still need more physicians in geriatric medicine, and we're really fortunate that we have a few really great ones here in Louisville, and Dr. D is certainly part of that team. So her research interests include multiple approaches to medication use and how health systems can drive polypharmacy and medication. She's the author of numerous publications. She serves as the Assistant Dean of Continuing Medical Education, and she works with a number of National Institute of Health funding and grants. So we welcome her this afternoon, and please come up, Dr. B.
Thank you, Mary, for the great introduction. Can you all hear? Good, good. Please call me Dee for obvious reasons. Demetra, Antimisiaris is too much for most people, including myself. As mentioned, I'm here to talk about polypharmacy, and just show of hands, how many people have had at least one medication misadventure in their lifetime? I have. So we're going to talk a little bit about how we've come to get in this situation as a society, and then we're going to talk about how we can defend ourselves to against the system that's actually perpetuating polypharmacy. So we'll talk about your handouts in the end, but let me just start with our topic, which is polypharmacy. And I want to start by defining polypharmacy. Poly means many, pharmacy means medications. And you can see that there's a textbook definition, which is 5 or more medications taken at the same time. That's what the medical literature considers the threshold for polypharmacy. But the one that I like is more medications than are clinically needed or needed. And we're going to talk a little bit about this. If you take nothing else from this, take home that if something's not working, don't take it. Don't take it just for insurance. Don't take it just because it might work. Make an effort to see if it's working, and if it's not, think about deprescribing it. Some people have called polypharmacy a random, uncontrolled experiment. So for those of you in healthcare, that's a pretty controversial statement, because all we do is evidence-based medicine, right? Our guidelines are based on randomized controlled trials. The problem is those trials don't include your individual self with all the stuff that you take and all your problems. They take 2 groups that are equally matched, they try a drug, and then they get the results. But then they go ahead and use the drug in somebody who's got a totally different circumstance. So in some ways, the way we combine meds and the way we use them is a little bit of a randomized experiment, but uncontrolled. There's a lot of different types of polypharmacy. So when you see the word polypharmacy, it could imply inappropriate medication use, like using too many combinations at the same time, wrong doses, wrong prescriber, wrong overseer, things like that. It can also include how people use medicines in their day-to-day life. I'm very interested in this. In fact, I'm doing a session on falls at American Geriatrics in a couple of months, and I'm actually, don't tell my mom, using her as an example because she mysteriously found herself fallen in front of the stove. Nobody was there, nobody witnessed it, but I noticed that she'd been self-managing her medicines wrong, and the clue was her blood pressure. Her blood pressure was so low after years of being high, and then I looked at her meds, and she'd been double dosing and doing all these things that causes falls, right? So polypharmacy includes the person's experience. I always want to know, what is the patient's medication experience? So I'll dig pretty deep and ask, on a typical day, how do you take this or how do you take that? And find out. The other type of polypharmacy is that which is driven by the healthcare system. And so, after 10 or 12 years of educating physicians on skills to clinically manage polypharmacy, the light bulb went on in my head that it's really not them that's the problem. It's not that they don't know how to manage it, they're not given the time. So if you have a 15-minute office visit and you've got 10 medications, do the math. Nobody's really looking or has time to look at the overall medication cocktail. So polypharmacy is driven by short office visits, multiple specialists. Because remember in the old days, when a lot of us were young, we had one doctor, and that one doctor knew everything about you, your family. They took 45 minutes with you or half an hour. So they knew what was going on. You went to the hospital, they went to check on you. So part of this is modern healthcare. The other part of it is modern technology, which is getting a little bit ahead of our ability to manage it, like every other technology. And to be honest, I don't think there's anything we can do about it, which is why it's important for us to take it upon ourselves to know that. For example, every year about So last time I looked was the other day, but last time I updated this was 2018. In 2018, there were 60 medicines that came on the market that year. This year, in the first 3 months, I counted 60 already. So maybe there's gonna be 100, right? How many do you think get pulled off the market? I looked at that too, in the past 10 years. One. So that's what's happening, right? We have 20,000 prescription chemical entities on the market, and we have 300,000 over-the-counters, and then that doesn't count all the supplements. So you start putting all those things together, and let's be honest, even if you're a skilled bench pharmacologist working with a skilled clinician, it would be difficult to predict what's going to happen when we start combining these things. So this kind of makes an argument for less is more, right? Just to be safe, less is more. The other thing about the over-the-counters that I'd like you to realize is that many of them were prescription at one point. So does anybody know why the FDA makes a drug a prescription as opposed to over-the-counter? Because they've determined that it takes some level of monitoring, right? It's not safe to just let out there for the public to use. So you kind of ask yourself, well, why was it prescription then and now it's not? Like Prilosec, for example, or those gastric drugs, they used to be prescription, so now they're not. Why? Money. Okay, there's the real answer. And that comes down to the patent. So that's one of the reasons. And so you have to realize that more and more products are coming on the market that are potentially hazardous. The way it was set up when we first started mass manufacturing medicines was the doctor became what they call the learned intermediary. So this is a legal term that meant that drug companies were not liable for the outcomes because the learned intermediary is the one who's recommending them. So again, that was back in the Marcus Welby days when there was a learned intermediary and there was a small handful of drugs that they understood. But today, that's not the case. But that law still kind of exists. So we've got some ethical problems in our health system that has to do with why polypharmacy is a serious threat. And you'll see some statistics on that in a minute. So what you see here is a patient in California. They're taking those prescriptions, a couple of things for anxiety and depression, a couple of things for prostate, urinary frequency, but all that other stuff as their main regimen. So the problem is it's hard to know what's in there. Like, you don't know what's actually in there. Does anybody know why supplements are dangerous in terms of knowing what's inside the bottle?
Does anybody know what about?
Why are supplements tricky in terms of what's inside the bottle?
Oh yeah, because if you don't know what's in there, you maybe already having a whole bunch of it in some other form.
Yes, you can easily duplicate, right? They have kind of like brand names that are a mixture of a lot of different things. The other reason is that supplements are treated like foods in that what's inside the package doesn't necessarily have to match the label. So FDA approved drugs like over-the-counters and prescriptions, what's inside the bottle has to match the label in strength and content. So if you were to look at the FDA website on supplements pulled off the market, you can get these alerts. You'll see a lot of supplements pulled off the market because they actually had real drug inside of them. The most common being the erectile dysfunction drugs, supplements, and inside the supplement is actually Viagra when it says it's a supplement, okay? And so you're thinking, okay, this is getting really scary. One thing I will share is that if you want to know that a supplement has been tested for ingredients, there's a little sign on this called a USP sign. You've probably seen that. Some brands, some of the Costco brands have that, and so does Nature Made has a lot of those little USP signs. That's your kind of guarantee that what's inside's on the label. So why is all this polypharmacy a concern? it's the logical relationship between adverse outcomes and number of meds. So you can see from this old graph from the 90s, there's a linear relationship between number of medicines you're taking and risk of adverse outcomes. And when that number, see here at 5, the more you take, the more risk you have of having an adverse outcome. But when it hits like 7 or 8 or 9, it starts becoming more exponential. And that's why when they come to the nursing facility or they come to the hospital, the surveyors will look straight for the patients that are on 9 or more medications. It's based on this old data showing that your risk increases a lot as you go higher. But here's the real stunning statistic. My friend and colleague, Jonathan Watanabe, he's at University of California, Irvine. He's a pharmacist but an epidemiologist. And he did a study looking at non-optimized medication therapy and linked to mortality. And he found that non-optimized, that means well-intended medication use that's not quite right, leads to 275, almost 276,000 deaths annually. This was 2016 numbers. And if that were counted by the CDC as a cause of death, it would rank as the 3rd leading cause of death. But the CDC does not count suboptimal medication use deaths as a cause of death. Okay, then after this, COVID happened, and COVID became the 3rd leading cause of death. And now COVID's kind of calming down in terms of a cause of death. And I think he's working on another analysis to see where it's at now, because since 2016, more drugs are on the market, right? So we're not talking medication misuse, we're not talking, opioid abuse, we're talking, we tried to use the medicine right and it went wrong. So it's a very significant cost to society. It's just kind of under the radar. Also, it's important to understand that in our region, we have more polypharmacy than most regions. This is the scripts per capita from the Kaiser Foundation data. And if you notice, this is just over the years, right? It kind of goes up and down, but Mississippi, Kentucky, West Virginia, Tennessee, Alabama, much higher prescriptions per capita than places like Colorado. Okay, Alaska, you could imagine, right? You don't have access to get prescriptions, so there's not that many. But places where it looks like this on the map, this is the exact same map as the obesity or BMI map. So really it's linked to chronic disease, and if we could, as a culture, pay for lifestyle and wellness, we would, I think, impact the amount of medications we're using. If we poured that money we're spending on medicines into helping people live healthier, it would probably make a big difference. But then again, that's over my pay grade, right? That's a policy thing. I've tried presenting this around, but there's a lot of competing factors, you could imagine. Okay, so how did we kind of get into this mess? This is a timeline of kind of to give you an idea that modern manufacturing of medicines really didn't start until after World War II. Until then, when you went to get medicine, you'd go to the pharmacy and the doctor would write you a prescription. Let's say you've got a headache, and they'd say, okay, you need to take some cocaine, and the pharmacist would put it into some sweet syrup and make a soda out of it, and then you drink it. And that's how they used to prescribe in the old days. You've seen those soda fountains, that's why they evolved, is to make the medicine taste a little better. But after the war, they started to manufacture antibiotics, and then in the 60s and 50s, end of the 50s, a big development of psychoactive medicines occurred. And what's interesting, for example, you think of the drug Ritalin, right, for ADHD. It was first put on the market in the early 70s, late 60s, for kids who had intellectual disabilities. And then, of course, it failed because just taking some amphetamine is not going to fix that, the problems associated with cognition. So they pulled it off the market. But when ADHD was part of the DSM-5 or whatever it was, 4 or 3, they said, oh, here's an opportunity, and they put it back on the market. So it's interesting to kind of look at the history of some of the products that we are given, and how did we come to get to this point? And you look at some of the advertising that you see on TV today, you guys are all probably old enough to remember that it was not legal to advertise prescriptions on TV, maybe 15 years ago? It wasn't even legal. And now they just make people look like, oh, I'm dancing through the park on this medicine and I feel all better. And they're talking about like serious diseases and serious side effects. So it kind of conditions people, and that's unfortunate. This is something called the Orange Book, which was a way to kind of regulate like a compendium of all medicines. They've now had to make a Purple Book. Purple Book is for the biologicals, like rituximab and all the biological medicines that are coming on the market in droves. Those are a whole nother ballgame. The tablets that you take, they go in the stomach, they go through the liver metabolizes them, and then your body lets it out through your kidneys or whatever. Biologicals are different. And let's say the COVID vaccine, it's a biological. It is made of a protein, and your body just kind of breaks it apart into amino acids and absorbs it. So it's metabolized differently. So the half-life is different on biologics than it is on regular capsules and tablets that we take. One, for example, is something you can take for asthma. It suppresses your IgE, which is something that makes you sick when you have asthma. If you get in trouble with that drug and you stop it, the half-life of that drug is nearly a month, and it takes 5 half-lives to clear your body. So I'm not saying all biologicals have that kind of half-life, but they have very unpredictable behavior in the sense that A, they're new and we don't fully understand them, and B, a lot of our doctors are not trained about how to assess the half-life of a biological, what the effects could be and how long they could last. It's like they've got to stop what they're doing, dig into it, and in that 15-minute office visit, they can't do it. So again, this brings it back to, I would like to put the idea in your head that whatever you take, you need to be very familiar with it. Just because probably it would be very hard for the people taking care of you to catch everything. So that's the thing about biologicals I wanted you to know. Okay, I'll skip this, but this is just like the long-term history, which I just kind of described to you, of pharmacology. Consider that we didn't even understand the human genome until the 90s, right? And now we know the genome interacts with drugs. Okay, so what I'm saying is we're kind of flying on instruments, and we're in a storm, which is okay 90% of the time, but sometimes it's not. I'm going to go quickly through this in the interest of time, but part of the main problem is medication use should be individualized. And we have randomized controlled trials where you take 2 exactly matched groups, you try the drug and you look at the difference. So here's an Alzheimer's drug trial that came across my desk, and that's the exclusion criteria. Like, you can't be in this trial if you've got a diagnosis of dementia, but if you have any other kind of dementia than Alzheimer's, you can't participate in the trial, which is going to bring this drug to market. Well, the problem is we don't know that somebody has just Alzheimer's unless we do a brain biopsy, and no one's going to do that, right? So we're guessing. And then you can't be in the trial if you've had a heart attack or you've got cardiovascular disease. Well, the number 2 cause of dementia is cardiovascular disease. So this drug, if it had come to market, which it didn't, if it had come to market, it would have been tested in this real narrow group of people, and then it would be used in everybody else. And that's why things go wrong, because when a drug's new to market, we only have so much information. So as a general rule, when a new drug comes to market, in geriatrics, we like to say wait 7 years. So, now of course, if you're in a situation where you need something now, because you're not gonna live 7 years, I'd say try it, right? But if it's a drug that you're taking just for something that's pestering you, then I would wait until it's been on the market for a long time, until we understand it very well. So we test it in these people, and then we use it in individuals, and that's the problem. So the other thing remember I was saying, if you take nothing else from this, make sure what you're using is effective. Here's a paper that was in the journal Nature, and it showed efficacy rates of some drugs. So, for example, Abilify is for like dementia behaviors or psychosis. So if you give it to 5 people, it's only going to be effective in 1 person. And we can't predict that, but that's why it's important to know, is this really working? And one of them, one class of drugs that almost always is ineffective are urinary incontinence drugs. There's a study that showed that within 4 months, most people taking urinary incontinence drugs discontinued them because they were not effective, they didn't make a difference, and secondly, they caused side effects, like serious side effects, like confusion and problems like that, constipation. So for some people they work, but if you're not that person, don't expose yourself to it. That's kind of the point. Is polypharmacy hazardous for everybody? Not really. The younger you are and the more physiological reserve you have, the more you can tolerate the stresses of taking a lot of medicines. And this study showed that in younger people, 20 to 49 years old, polypharmacy is very tolerable unless you're taking 10 or more medications together. But in older people, people start having adverse outcomes when you're taking 5 or more medications together. Why? Because you have less physiological reserve. Your ability to tolerate any kind of insult to your body, it has to do with how much reserve you've got. If a 10-year-old's kidney is probably just like every other 10-year-old's kidney, but a 60-year-old's kidney may be very different than another 60-year-old kidney, depending on if you've had diabetes all your life and if you're taking diuretics and all this stuff. So in older adults, the criteria, the threshold for having adverse events is much lower. Makes sense, right? This is why the American Geriatric Society has this program called Choosing Wisely. Every specialty has a Choosing Wisely list. And that's a list of 10 things that you should talk with your doctor about, and your doctor should talk to you about. 7 of the 8 American Geriatrics items are medicines. And that goes to show how prominent medications are in the lives of older people, and that we should be talking about some of these, and they're highlighted in this, which is in your handout. And I gave you handouts so you can go to your doctor and use it as a prompt and talk about stuff. So, all right. So what happens when we deprescribe? Mary mentioned deprescribing, which is an important thing to do. It's being vigilant about what you're taking. This is a study done by Doran Garfinkel. He's a deprescriber in Israel, and he's done some really good work. He looked at long-term care patients, nursing home patients, who obviously are the more sensitive to medicines, and he deprescribed 2.8 drugs on average in the study group, and then there was the usual care group. And the drugs he deprescribed were the ones that he knew they didn't need, like the 3rd laxative on the order set, or nitro when the person was not walking around and not getting winded anyways. They never used the nitro, so he took those away. And what he found was pretty astounding. He found that the 1-year mortality rate in the group that had deprescribing was half that of the usual care. And the rate of going to the emergency department for the study group was 11%, but for the usual care it was 30%. So in terms of keeping people out of the hospital and decreasing risk of mortality, less is more, right? That doesn't mean when we deprescribe, we don't want to abruptly stop medicines, because that can be dangerous too. You can have bad reactions. But if you carefully deprescribe, it really helps. Okay, so the other thing I wanted to show you is that prognosis is important. The decision to keep a drug or not has to do with whether it's going to benefit you, right? And some conditions, you have to manage them for several years before you get benefit. Anybody think of one common chronic disease that you have to keep, like your sugar's really low? Right, diabetes, right? If you keep your HA1C, that's a measure of diabetes control. If you keep it really low for like 10 years, you will prevent eye trouble, kidney trouble. But what if you don't have 10 years in your lifespan? Then what happens? Then you try to keep the sugars really low and you cause hypoglycemia. And that means low blood sugar. And if you have low blood sugar, you can damage your brain. So what does that do? That really impairs your life in a bad way, because damaging your brain is, impairs your functional status, and it threatens your independence. So it's a balance between, do we manage the diabetes to benefit in 10 years, or do we avoid hypoglycemia to benefit now? And that's why when people are over 80 years old, the recommendation is that we kind of just relax the diabetes goals a bit. And we did a study in our clinic where we asked people, what do you think about relaxing your diabetes targets? And they said, well, we didn't know it was going to go away. Like, they couldn't wrap their brain around relaxing their diabetes sugar levels, because they worked so hard all their lives to keep it in check, and they almost didn't want to. So it's kind of interesting. So it depends on where you fall on this spectrum here. And there's some tools that you can use to understand like what medicines are appropriate depending on where you are. So there's something called the start and stop and the Beers criteria, which lists medicines that are dangerous for people who are becoming more frail. And then there's something called the Canadian Deprescribing Network. If you Google that, they have a very nice website where they talk about different classes of drugs, what are the considerations, and how you might think about deprescribing them. One of those is, for example, the stomach acid drugs, the Prilosec I was talking about. What happens if you abruptly stop that? Do you know? Yes, you can get like more acid, right? And it's called rebound acidity. So you have to kind of slowly decrease it and let your stomach get used to it. That's the kind of thing they talk about on the Canadian Deprescribing Network. They have a lot of good resources there. So what happens though if you want to predict somebody's prognosis? That's not that easy, right? And we never know our lifespan, obviously. So I'm not going to pretend that we do, but we do have tools to help us in some situations. So dementia would be one, and dementia has kind of a different kind of prognostic tool set than just overall. If you want to look at overall lifespan, prognosis, you can use a tool. I don't know if you can see this down here. It's called e-prognosis, lowercase e prognosis. And that's kind of a little calculator online that's put out there by the University of California, San Francisco. And you can put in, it'll ask you, have you ever had cancer? Do you drink? Have you smoked? Have you had this? Have you had that? And then you put it in, and it kind of estimates, based on population data, what your prognosis would be. The warning about that is you always have your exceptions, right? So you heard about the lady who passed away in South Africa who was 123. Well, if you put her info into that, just based on age, it would have said she had a year to live, or no years to live, even without any diseases, right? So you can't really trust that necessarily. But it can give you an idea if you're trying to make some decisions. Okay, so let's look at a lady named Polypharmacy. And she's got a diagnosis of early stage dementia. So this is one clinical rating tool. It's called the CDR. You could easily find that online. And it asks you questions about, community affairs, hobbies, hobbies, you know, are you still doing those things? So let's plug in Polly's data. Now what we see with her is that her CDR is 1. That means that her cognitive impairment and dementia is early stage. And we know that with early stage, people have about 10 years or so, depending on the type of dementia. Not everybody, but in general. So that then brings into question time to benefit. So this is an important paper that came out by this group in JAMA that asks these questions. Will this drug help? When will it help? And how much will it help? Again, I always think about like the urinary incontinence drugs. Sometimes people take them and they don't help, but they just take them because they're expecting it will help. But if you look really closely at the data, if it hasn't helped in the first couple of months, it's not going to help. So the data actually shows that timed toileting and like keeping a journal works better. Timed toileting means you go whether you feel like you've got to go or not, and because you want to keep your bladder empty. It's when your bladder overflows that you get in trouble, right? So if you go every couple of hours on the money, chances are you're going to sleep through the night pretty good. But if you wait till the end of the day and then you go, your bladder doesn't fully empty. And then you go to sleep, and then next thing you know, you got to get up and go again. So that's why the science shows that time toileting and behavior feedback works better than medicines. So this is just the information on, you estimate somebody's lifespan, and then you understand the lag time to benefit for the medicine you're taking. And if the lifespan is greater than the lag time to benefit, then the intervention may help, but maybe, but if the intervention is, if the life expectancy is less than the time to benefit, then it's probably not going to help, and it might likely do more harm. And if it's equal, then you've got to start making a judgment call. So here's Polypharmacy, and she's 74 years old. She's got the mild Alzheimer's. She's got high blood pressure, high lipids, meaning cholesterol, type 2 diabetes, and insomnia. And she's had a recent weight loss. She's got difficulty managing her finances, and the tug and tandem stance score indicate that she's having a little trouble walking, so she's a falls risk. So here's her blood pressure. It's 129/79, and her HA1C, which is her diabetes, is pretty low. It's 6, not bad for her age. And she's got osteoporosis. You can tell by her T score. Okay, so let's take a look at her life expectancy. Remember I was telling you about that E-prognosis? This is how it looks. It asks you all those questions. Do you have heart failure, all this stuff? You plug it in, and in her case, you get a 9 to 10 year life expectancy. So that tells us, when we go back to her medicines, what to kind of think about. So she's got cardiovascular medicines like losartan and atorvastatin. Losartan's for her blood pressure, atorvastatin's for her cholesterol. She's got glipizide and metformin for her diabetes. And then she's taking tolterodine as a bladder medicine. So what does the data show us about time to benefit? Remember, we want to tie this back to time to benefit. Is it worth keeping her blood pressure low? The data is very clear that 1.7 years, about 2 years of blood pressure control can prevent 1 stroke in 200 people. If that's me, I'm going to take my blood pressure medicines because I don't want a stroke, right? If you look at cholesterol management, 2.5 years of taking your cholesterol drug like Lipitor can prevent 1 cardiac event in 100 adults. So that's even more beneficial than the blood pressure, right? You take your statin, if you can tolerate it, do it. And even if you're poly, right? Even if you're in middle stage dementia, it's still worth taking, right? Because we're talking 1 or 2 years until benefit for these drugs. What about her glucose, her blood, her diabetes? Now that's another story. The data shows us that intensive control doesn't really benefit some of the big problems that we're trying to prevent for 10 years. So in her case, we know that she falls. We know she's trying to preserve her thinking. So we don't want to risk low blood sugar in her. Because if that happens, it'll worsen her thinking and she could fall. And then what happens if she falls? She loses her independence maybe, right? Because she's got osteoporosis. So we don't want that to happen. So speaking of her osteoporosis, what about the time to benefit in taking, Fosamax type drugs for your bones? She's never taken any. She's got osteoporosis. You think she should start at this late stage? According to the data, yes, she should, because you only need to take it 1 year to prevent one non-vertebral fracture for 100 people. So I'd say, why not? If she can tolerate it, yes. And on that ePrognosis site, there's a little tool that you can look at the different types of, not every drug, but some of the main drugs that you might take, and look at life expectancy. And this thing kind of, she's right in here, there's Polly, right? This thing kind of slides this way. And you can see the green means, yes, you should still treat. When you get to the red, don't bother. So that's kind of a handy tool that I thought you guys might want to see. Now, I'm not recommending that you self-manage everything. Just be clear on that. But these are tools to help you talk to your doctor and ask. Okay. The other thing I want to mention, I mentioned that individualization is important. American Geriatric Society realized that this is way too complex for everybody. Like for professionals, way too complex. So they came up with what they call the 4 M's and the 5 M's. And it's kind of like a framework to help providers, physicians, people think about what are the considerations that you have to decide for each decision in your healthcare. You have to optimize your medication or your mind. You have to optimize your mobility. You have to optimize your medications, and all that tied into what matters most to you. And that's the individualization part. As we get older, we can't get back some of the functions we had, but we can optimize what we do have and try to not make it worse. And this framework really helps. So let's go and take a look at Polly's meds again. What does that mean for her meds? So you think probably we should keep her cardiovascular meds? I think so, huh? And then what about her diabetes meds? She's at 6% right now, HA1C. That's pretty tight control. She could go up to like 8% and it wouldn't hurt her a bit. So I'd say let's let those go. And then the tolterodine. So just so you know, it's the 4 M's. You might see the 5 M's. The 5 M's is to help people think you got to balance it all out, multimorbidity. So let's take a look at her tolterodine, that last bladder medicine, and try to figure out what to do for her. If we go by the 5 M's, tolterodine is a medicine that's strongly anticholinergic. It's like taking a Benadryl. It's not supposed to cross into the brain, but when you have dementia, things cross into the brain that shouldn't. So it can make her very confused. So not a good choice for the mind. How about mobility? It's linked to falls. But then so is urinary incontinence, like going to the bathroom all the time, is linked to falls. So you gotta balance that out. If it's working, then maybe, but if it's not working. Medications, we want to decrease her drug load. What matters most to her? She doesn't care that much about her urinary incontinence. She cares a lot more about optimizing her brain and not fall. So basically the decision comes down to, let's take that one off. All right, so, but then you gotta go back and talk to people. And not just the patient, not just the family, but the prescriber, right? The urologist is gonna say, well, why don't you want the tolterodine, What else are we gonna do? So you gotta convince them, and you have to say, because that's what I want. And here's why I want that. And in the end, you have autonomy over your choices. So communication about deprescribing is always difficult. Like I had recently a patient in the hospital who the daughter worked, the mom, keeping mom home with dementia. Without the sleeping drug at night, the daughter would have a hard time working because mom's up all night, right? But the sleeping drug is what got mom in the hospital. So we didn't want her to take that anymore. We were trying something else and the daughter said no. Because for that situation, it was the only way she could keep her mom home. See, so there's kind of no right or wrong. It's that everybody's different. And that's why what matters most means something. Same thing for her diabetes meds. I'm not going to go through this, but basically we decided to get rid of the metformin, which I've already talked to you about. So what about gaps in her treatment? We know she's got dementia. We took off her diabetes meds. We've added trazodone to help her sleep at night, low dose, because that's a big problem for her. We've added donepezil or Aricept to help her thinking. And we've added a bone medicine. So basically we deprescribed, but then we put back what's good for her at this time, which will change as things progress. So just remember that individualization of care is key. And those are the main things that I wanted to talk to you guys about. There's my information. If you guys ever want to reach out to me, Mary and her crew can give you my email. I'm always happy to answer questions and try to help where needed. Anybody have any comments or good stories? Because we all learn from each other. I told you my mom's story.
I'm related to your mom's story. I used to visit a friend of mine who was in her 90s, and she never took any medicine before 90. So
None.
she really didn't know how to take medicine. Anyway, one day I was there with her, and she said, "Will you cut this pill in half for me?" And I said, "Sure, you can go bottle if you want." Anyway, and she said, "I'm gonna take one now, and I'll take one about half an hour, because the doctor said take it twice a day."
Oh no. Exactly.
So some people really don't want to take medication.
So you're saying she'd never really taken anything until she was 90, and then she was given a once, twice a day, but she decided 1.5 hours from the other.
That's twice a day.
Wow. Yeah.
She didn't know how to even take Tylenol. She was in so much pain, and I said, "Oh, you should take, and so that, it's tough.
You know what? That's that whole point of these are kind of like high-tech gizmos. Drugs are high-tech, right? And we have to understand how to use them, or else they can be harmful or ineffective.
Well, and doctors need to know that, you understand how to take medication.
Yeah, I think what's happening is the doctors have their 15 minutes, they put in the prescription, and they assume that the pharmacist or the nurse will teach.
And they don't put it on your prescription bottle anymore.
No.
No. I mean, it might say take once a day or something, but for what?
But maybe for what, and it should be maybe specific, take in the morning at this time. Yeah, I agree. Yep, good story. I know. I thought of starting just a little podcast to put in our website where I talk to people about these stories, because other people go, "Oh yeah, I've seen that before." It's kind of like the hidden life of medication use,
You mentioned the Benadryl, and when Dr. Jane was here,
Oh yeah.
she referenced Tylenol PM.
Yeah.
And so it kind of came up in conversation that there were a lot of people who think that's a very safe thing to take at night, not realizing that the Benadryl might be just what you said, kind of contrary to clarity.
Yeah, that's that over-the-counter kind of it's how do you call it? Not divisive. It's
It seems benign,
It seems
but there's
benign.
really something going on, so I thought you might.
yeah, Tylenol.
talk
So
about that.
any of those PMs, the active ingredient is Benadryl, which is diphenhydramine, and that makes you sleepy, right? So it might have Tylenol in it. It might have Advil in it plus PM, right? Plus Benadryl. But studies have shown that if you take that over a lifetime, it'll precipitate dementia early. So that's number one for the young people. I always try to, you know, remind the students, don't get into this because, and they're marketed that way, like NyQuil. There's NyQuil, but then there's NyQuil for sleep, which is really the same thing, just repackaged. And yes, I'm glad that Dr. Jane brought that up because she was talking about keeping your mind healthy. And so not only is it harmful to you when you're older, but if you have any young people in your life, don't let them take it every night because now the epidemiological data is showing that exposure over a lifetime can get you to have dementia earlier. So it's not causal, but there's an association.
I have a question about urinary frequency in older people, of course. But when you watch the television advertisements and everything, the over-the-counter stuff, they're always talking to men. So,
Yeah, they are.
you know, if you call people up and you say, "Is this for women too?" They say, "Oh, interesting question." And then it's just like, "Are we in another world here, or what's going on?" I mean, you know, there are two of us. I don't know.
Well, you know, like there's such a thing called a man cold, right?
Oh yeah.
Well, it's the same thing. It's not that women don't get.
Do you have an industry with that about use for women? I mean, medication.
Yeah. So the one they're talking about for men is for prostatic hypertrophy,
Yeah.
right? And what happens is the urethra gets closed off, right? So that medicine is a little different than what women would use.
Yeah.
That said, the bladders are super complex. There are women who have really like obstructed urethras who would use that medicine, which is usually for men.
And if you didn't have that,
If you didn't have it,
there really is nothing out there for women's frequency. Like in a wide market span, nothing.
yeah, usually, yeah.
There's just
For-
nothing there. Yeah.
So for women, frequency is, so here's the bladder, and then here's the bladder neck, and then here's the urethra. There's 3 different things that can happen. One is too tight on the urethra, right? And medicines can cause that. Then the bladder can't empty fully, right? Or the bladder doesn't contract to empty very well. It's too relaxed. So if you take a Benadryl, and you take a Benadryl every day, not only will you not poop, but you won't pee. Excuse my language, but it does that. It relaxes your bladder, it relaxes your gut, and a lot of medicines, polypharmacy, a lot of medicines have that same property, just a little bit, and you start adding them up, and that affects your bladder and your bowels. So what happened is when you do go, your bladder can't empty fully. So there's the urethra, there's the bladder neck, you know, there's the bladder itself, and then there's 2 different systems that control it. One is you know, the flight or fright, you're running away from the dinosaur, and you're designed not to pee while you're running. So that, any drug like Adderall or amphetamines would cause you to not be able to empty your bladder very well. But the opposite way, where your bladder's too relaxed, also can make it so that your bladder doesn't empty very well. What I'm getting at is, bladder inefficiency is so complex that it's not something that can be just treated without a good look. Urologists need to do that look, sort of. They need to do a study of pre and post void volume, and sometimes they need to do a scope and see what's going on in there, and then you'll get a better answer. But sometimes in very, very older people, you know, like my mom's 96, right? The best bet is to have depends and have backup systems so that if you do not make it, you're not tripping over yourself trying to get to the restroom, and that you're able to clean up often. And you know, in some ways that's a hassle, but it's better than harming your brain, you know.
Well, it's just like everything about females, just a little bit more touchy, a little bit more complicated. So, you know, there's no reason for me to expect that they really have gotten anything improved yet.
Well, and it is interesting that you that you hear a lot about, you know, the prostatic hypertrophy. It's all over the media. Like, oh, that's a huge problem. Yeah, it's like a man cold.
Do you have any thoughts on DNA testing for determining most effective medications?
That's a good question. So there is this DNA
I
testing.
didn't hear the question.
Okay, the question is, DNA testing to determine what your dose of the medicine is or which one's the most effective. So just a quick history. Medicare gave a really robust reimbursement for that test, and they gave it to anyone. So what happened was all these labs popped up everywhere, and they were constantly knocking on our door, hey, swab all your patients, swab all your patients. And those people who did swab their patients and do the genotype, it's a one-time payment. And so if that clinic couldn't figure out what to do with the information, then later on, 10 years later, if they swabbed again, it wasn't covered. And the problem is, back in those days, nobody knew what to do with that information. Now we're getting more and more data, we're starting to see. What it will tell you is whether a drug will absolutely not work for you. Like, it'll tell you, like, oh yeah, you don't even metabolize this to make it active. It won't tell you what will work necessarily, because it doesn't take into consideration all the other stuff you have on board and how your body interacts with that drug. So we'll at least eliminate the ones that won't work.
Okay,
Yeah, so that it's not a bad thing, but it's a developing science.
okay, thank you.
Yeah. Did I run really late? I'm late, huh? You guys okay? Okay. Anybody else have any comments or stories? Oh, one quick one.
I do just, I had osteoporosis, and when I found out, this doctor that I went to, she right away wanted me to take this drug that I do see advertised on TV now, but this was 2 years ago.
Mm.
And it's called Demetra, and I did some research about it and looked stuff up, and it had just been approved, and had this black box warning on it, and so,
The thyroid thing.
well, I don't remember what, it was just a black box warning that could cause death. And so,
Oh, is that all?
I just talked to some other people, did some research on my own, and just kind of what you said, like, bound date is what I would think now. But that it was something that's been around for a long time, Bostonized, and
Right.
so they know more about, the side effects and stuff about it more. It's been around for a while longer, but
Yeah.
the question is, it's like, when you're talking to these doctors, because this was a doctor who I liked a lot, it's my gynecologist, but when I went back to her, I called her and asked her, why did she prescribe that for me? Like, why did she try, something that's brand new, and she just said, well, because it builds bone, and she didn't really give me a good answer, and then I feel like our relationship after that, like, I still see her, but it's almost like, why didn't you, it was like she's almost upset that I questioned her.
Question
or
that.
I didn't do what she said, because it's to the point where I'm thinking, I really had always liked her, but I'm thinking about switching doctors now, and so, like, maybe what advice do you give to someone, because some of these doctors, it's like, hey, it's my life, it's my, but
Yeah, the question is about kind of the awkwardness of questioning your doctor's suggestion, and unfortunately that is a real thing. My whole career was that. So before I came here to UofL, I worked in skilled nursing facilities, and it was my job to question physicians, and you learn quickly how to do it to help them. That's kind of the framework that worked best for me, which is, I'm not questioning you, but I have this concern and that concern, and here's what I would like to do, and I will consider what you're recommending. So what she recommended to you was, there's 2 different kinds of bone treatments. One stops your bones from like losing calcium and all that stuff, and eating away at itself. But another, the kind she recommended, builds bones back. So they each have a place, and it would be good over a lifetime to take both at some time. But you're right, wait until this is on the market a little longer, and go in to talk to them with the most information that you can, the most logical, and you will sometimes have the personality that gets upset when you question me. But if you frame it as, you know, I don't want us to have problems down the line, and here's why, usually it works. But you know, good for you for standing out, you know. And you know what, not every drug is dangerous. Like, every drug has a danger. I'll take that example. I'm at the osteoporotic age, and I know that I have to start taking something, but I'm waiting because I know I've got a dental problem here. And if I start taking that alendronate now, I'm gonna potentially end up, I have a risk, right? So I'm gonna fix that first and then. So, you know, if somebody asks you to say if a drug is good or bad, you can't, because for every person it's different. And at different times, it's different too, if that makes any sense.
You didn't even tell me that. I know exactly what you're talking about. So because I had researched it on my own, then when I went to my dentist, I asked her about that, and she said just exactly what you said. She said, if you needed to have anything done, like
Any kind of planing or,
like, yeah, if you had like an implant or something where they're going into your bone, that you would need to have it done now before, you know, which I appreciated her telling me, and, you know, I didn't need anything, so I was fine, but the doctor who told me, she never even mentioned that. So how did she know that I didn't have
yeah.
something wrong with my teeth?
I know, and this is the sad thing. She was not malintended, right?
Yeah.
But you did the right thing and educated yourself. So that's kind of what we're up against. Yeah. So that's why I invite you to ask me any questions.
I was gonna ask kind of exactly what she was. What is the best way? Like, my mom's in her 90s, so when I go to the doctor with her, what is the best way to approach? Like, would it say, here's her list of medications, is it possible that we can take her any?
Yeah.
Because it seems like you can't go to a doctor now, everybody's a specialist, so.
Yeah, I know.
Do they know? It's difficult because I know that they're looking at a small piece of the pie, but yet,
Yeah.
that's their priority, so how do you?
That's what
without-
Dr. Murphy, who's going to come and talk to the group in June, he taught me a lot. He's a family med doc around here, and he retired. And he goes, there's no captain of the ship. And that's what the family med doc used to be, or should be. So if you have a primary, right, I would say that person. And come armed with the information. Like, you might want to go to e-prognosis and do the calculator in case it hasn't registered in the head of the specialist that, oh yeah, this person's life expectancy is 3 years, so maybe we shouldn't start, you know, this, that, or that. Is it gonna benefit, you know? But definitely the
Because,
primary.
you know, it almost seems like, you know, and I'm not going to the doctors at all, they give them 5 minutes.
It's terrible.
Chart review and run in, and like they're running out.
Yeah.
Like, that's gonna take up how many more minutes to ask about, you know, so who knows, because the office staff doesn't know, and then you can't call and talk to the doctor. It's always, well, we'll get
I know what you mean,
someone
like,
back, and you can't ever.
you can't get a
communicate.
word in edgewise, sort of. I'm a fan of providing documentation, so write out what you wanna know about, and ask them to scan it into the chart, and ask them to read it, just in case you won't have time to talk about it. I'm actually, you know, doing a study on medication reconciliation in the clinic. You know, when you go, the MA says, are you taking this, are you taking that? Well, that's an opportunity to get a lot of information, and from my pilot study, I find that they're not getting much, right? And then when I brought that data back to the administrator, the hospital administrators, they kind of said, well, see, what they're interested in is how does it affect our outcomes, because that means money. So what I'm trying to do is work on how do we make those systems such that the doctor will have time and connect the dots so that they know that if they pay attention to the medicines, they will make money, right? So that's kind of the environment that we're in right now, and it's all driven by insurance reimbursements. So best thing you can do is you know, if you have medicines that you don't think are benefiting her after you research them, then write them down and ask. And the other thing is, go to drugs.com. You heard of drugs.com probably? They have a drug interaction checker, and you can put your list of medicines in there and hit, you know, check interactions, and that's a good starting place. Because it'll tell you if one drug is like fighting another, like if your blood pressure drug's fighting your Aleve that you're taking. Aleve's raising your blood pressure, and the blood pressure drug's trying to lower it. So start with that, because that's irrefutable. Yeah.
Melatonin.
Melatonin.
Can you give your opinion on
Yeah,
that?
yeah, good stuff. Nobody likes it because it doesn't make you conk out and fall asleep, but it's almost like brain glue, sort of. Melatonin is used in the ICU in Europe for delirium. So people who are delirious, you know, they use IV melatonin, and it kind of helps reorient the people. The reason is our pineal gland in our head, it secretes melatonin. And as we get older, like every other gland in our body, it doesn't do it as well. So and especially because we're indoors, especially as we get older, we're indoors, and we're in front of computers. And so our natural cue for melatonin secretion is when we see sunlight during the day and then the sun goes down. But we don't do that anymore, right? So a lot of reasons why our melatonin is not working right. Melatonin does not induce stage 1 sleep, which is where you first fall asleep. That's why people take it and they go, oh, it doesn't work. But what it does do is it elongates your stage 3 and 4. You're dreaming, the stuff that makes your brain restore. It makes that longer. So you won't wake up as much in the middle of the night. You will dream more and you'll have that restorative. I've seen some products that have a pretty good combination that I think works for sleep. GABA, L-theanine, and melatonin together. And if you can get one that's a good brand like USP, you know, or actually I've seen one at Costco, not to endorse in one place, but I've seen, and it works pretty well. Like if you compare that to taking a sleeping pill is like this strong, and that's like this strong. You don't need this strong, right? Because if you take this strong, the next morning you'll have trouble getting up. But if you take the less strong, and think about melatonin, you have to take it every single day for a month, and then you'll start to see the effect. Yeah, good question. Actually, the more I read about it, the more I'm convinced it's we can't sleep because our melatonin secretion's all goofed up.
Are there different strengths for that kind?
Oh yeah, the strengths, they come in like 2 to 10. Usually most people need 3 or 5. More than that, probably not. There's another hormone in your head or in your body that's released in the morning. It's called orexin, and that wakes you up, and that kind of gets you going. There's a class of drugs called orexin inhibitors, like Belsorma, you might have seen that, and they're used for sleeping pills, and they're kind of trying to work on that system. Okay, we're ready to wrap, and please don't hesitate to reach out to me if you need me. Thank you for staying, and thank you for a great discussion.